All right, so first of all, thank you guys for coming. Thank you guys for allowing me to come here and present. John, thank you for trusting me enough to bring me in here. I cannot say this enough because even at this point in my life, I'm about to turn 42, I'm retiring from the military, but being in the position where people come and want to hear me say something, it's still kind of surreal to me because I don't even like listening to myself most of the time. But very from the bottom of my heart, John, thank you so much for letting me come here. He said a little bit about my background. My background doesn't really matter that much other than the fact that I've been a licensed physical therapist for about a decade now. I went to school at Baylor University. At the time, whenever I went to Baylor University, it was a top 5 physical therapy program. That's really not all that important, other than the fact that I got through physical therapy school, became a licensed physical therapist, started practicing physical therapy as it was taught to me, and within about a year of practicing physical therapy as it was taught to me, I realized that physical therapy falls very, very short, especially with the population that we have in attendance today. So I've given talks plenty of times before, and typically what I end up giving the talk is more kind of along the lines of what you would see at a medical symposium or something like that, where I stand up here, I go through a review of the literature, I tell you what studies have found, like statistics based off of injury prevention, injury recovery, things like that. And on my way here yesterday from beautiful Wichita Falls, Texas, decided, you know what, I don't think that that's what everybody in this particular setting wants to listen to. So I completely revamped my talk on my way here. I do not suggest doing that 24 hours in advance of a presentation like this, but I thought what would probably be better for this particular population or demographic is actually give you some actionable intelligence on how to navigate not only your own training, injuries that occur during training or around training, and then also kind of give you a little bit of an overview of the American medical system and how you can be a more effective and more conscientious consumer of medical care. Now, all that to say, none of this is medical advice. I'm not telling you to not go to your doctor. I'm not telling you to go to your doctor. I'm not telling you that for your particular situation you need this test or that test. But as general education, I'm going to kind of walk you through our healthcare system and how you can be a more effective consumer of healthcare. So first things first, everybody in this room will get injured. And this is true regardless of if you're in the gym training, and it's true if you're not in the gym training. Everybody's going to have an injury. And we can just define an injury as some type of unpleasant sensory experience that prevents you from participating in your activities of daily living, all right? So that can be back pain, that can be shoulder pain, it can be anything that the unpleasant experience makes you stay away from some type of activity. Now notice what I said there is that it is an unpleasant experience. I did not say that an injury means tissue damage, that it doesn't necessarily require a broken bone, a torn tendon, a torn muscle, or anything like that. And whenever you look at the number of injuries that come into a physical therapy clinic or that goes into a primary care clinic, the vast majority of the time there is no actual tissue damage at that point. So it's very important that everybody understands that an injury does not require tissue damage to be considered an injury. It's just the unpleasant pain experience that prevents you from participating in daily living, all right? Now, like I said, everybody's going to get injured. Everybody's going to get injured whether they go to the gym and train. Everybody's going to get injured if they don't go to the gym and train. I've probably seen the overwhelming majority of individuals that I saw in daily clinical practice got injured doing things that they do in normal life. Getting in their car, picking their keys up off the ground, taking milk, of all things, taking a gallon of milk out of the refrigerator seems to be something that puts a lot of people over the edge. Now, just kind of as a group, whenever you experience some type of injury or even worse, you go on to a Facebook group or something like that and somebody posts that, hey, I have some shoulder pain, what should I do? What is the number one thing that everybody says that you should do?
Rest.
Rest? And then there's another thing that people tell you should do, right? Not so much anymore, but most people say, well, you need to go get it checked by a doctor, all right? So that brings us to the first part of this lecture is the American medical system, how it works, how it operates, and how it is not set up for you. The American medical system is set up as a cost-saving enterprise, and you're going to see that whenever you engage in medical care for something that is routine like a musculoskeletal injury, that I can go ahead and write the script for you how everything's going to go. And then once we get to the end of that, you kind of see, yeah, that's basically the experience that I've had. Then we can talk how you can be more effective in that. So what's the first person that you have to see in the American medical system? Generally speaking, there's probably some people here that are cash pay patients, or they have like a health savings account or something like that, and they're not constrained by their insurance setup as much as other people. But if you're in a health management organization or something like that, who's the first person that you have to see before you can see anybody else?
Primary care.
Your primary care doctor. All right, now, anybody in here has seen their primary care doctor for a sprain, strain, backache, something like that. That should be, for the most part, everybody. Now, out of the people who have been to a primary care appointment for something that, generally speaking, within 6 weeks it was better anyways, how many people were completely satisfied with the care that they received at the point of care by their primary care physician? Primary care physician, PA, nurse practitioner, whatever is your primary care manager. How many people were completely satisfied with the care that they got? I don't see anybody raising their hand. I don't see anybody nodding. Now, out of the people who have been to a primary care physician, nurse practitioner, PA, something like that, how many people have experienced this? You make an appointment. It takes you 2 to 3 weeks to get in. You go in, you sit down, a medical technician, an administrative person, an LPN, some type of technician sits with you, takes your whole history. They take your vital signs, stuff like that. So you're there, you've probably been there 15, 20, 25 minutes just answering questions. Then whenever the actual provider comes in, you get about 2 minutes maybe, with that particular provider. They give you a recommendation and then they leave, and then you're turned back over to the technician or whoever to escort you out to go make your follow-up appointment. Does that seem to be more along the lines of what most people have experienced? For not necessarily like if you go and you see a neurosurgeon or a rheumatologist or a subspecialist like that, you're going to get a little bit different care. But we're talking about the primary care environment. Does that seem more along the lines of what people have experienced, right? Yep. Now, you have a little bit of shoulder pain because and let's say you've been training at this point for 6 months. Your shoulder's been bothering you a little bit. You go into your primary care doctor. That physician steps in, and within 30 seconds of being in there, what have they all told you to do? Rest, of course, because it takes 12 years of medical education to tell somebody to just rest, right? Now, in some cases, there are some pathologies where rest is absolutely indicated. Broken bones, stress fractures, things like that. There are tissues in the body that do heal passively, but muscle strains, sprains, tendon-related pains do not do well with rest. But if you step back a little bit and you think about this, what was it in that 2-minute appointment that you had with that provider that they were able to actually assess what was going on with you? Now, some of the more experienced providers may come in, they may kind of twist your arm a little bit, take you through some whatever special tests that they remember from 20 years ago whenever they were going through their residency or their medical education. But they do a couple of tests. They listen to your breath sounds. They listen to your heart, and they say, "All right, you just need 6 weeks of rest." All right. At that point, would anybody in here say that they got comprehensive care for that particular condition?
No, sir.
No, you get a prescription of rest, probably either acetaminophen, Tylenol, ibuprofen, something like that, something to help manage the pain. Take 6 weeks off, and then what do they tell you to do?
Come back in.
Come back in. All right. Why do they have you come back in, and why do they have you come back in at 6 weeks?
Assess whether you feel better.
Yes, because at 6 weeks, the natural progression of most injuries is that it's going to be better at 6 weeks, because that's kind of the basic timeline for tissue healing. So if you did have a minor injury, within 6 weeks, the overwhelming majority of the time you're going to feel better anyways. So guess what you're not going to do? You're not going to make a follow-up, or you're going to make a follow-up just because you feel obligated to let the physician know that you're doing better. You come in, you see that physician, you tell them you're feeling better, and then they say, all right, well, best of luck to you. We'll see you for whatever you come in for next time, all right? So you have that. But what happens if you come in and it's 6 weeks later and you're still having problems? Then what occurs?
PT, referral.
Most of the time, they're probably going to get baseline images, right? So you're 20, 21, how old are you?
19.
So 19 years old, you have a little bit of shoulder pain that has come on whenever you're training. You come in and 19 years old, you see your primary care physician, they say, hey, take six weeks of rest, here's some Tylenol, some ibuprofen. Come back in 6 weeks if it's not better. Come back in 6 weeks, it's not really all that better, but you're looking to escalate care. You want more care, kind of pin down what's going on so that you can effectively manage it, right? They're going to do an x-ray. Why do they do an x-ray? Because most people, I would say that probably within this population here, people in attendance, people are going to say, well, they want to get a look at what's going on. They want to see if they can find what's causing the pain. That is absolutely not the case. That is absolutely not the case. There is nothing about this particular situation that says that there is a bony pathology here, because he didn't have trauma. We're not thinking that he has cancer. We're not thinking that he has a tumor in his shoulder. This is probably musculoskeletal in nature, but why do we do the x-ray? We do the x-ray because it's cheap, and we can do an x-ray. We can tell him your x-ray is normal. Come back in 6 weeks if it's not better. We do that because insurance companies will not typically allow for advanced imaging for somebody who has not had a lower form of imaging before that. So he comes in, he gets the x-ray, we give him 6 more weeks. He comes back in 6 weeks, it's still not better. We have imaging that says that the bones are normal. At this point, what do? At this point, probably the vast majority of your providers, because again, remember, a nurse practitioner, a PA, or a family medicine doctor probably sees somewhere between 40 and 50 patients a day. So they have 2 to 3 minutes with a patient to make the right decision. So think of it as like a filtration system. You dump a whole bunch of patients into their schedule, and what they're going to do, because they don't have time to do a lot more than that, is they're going to take the things that are immediately troubling, that require more in-depth investigation, and they're going to put a lot of resources to that. So somebody comes in with medical red flags, and they're going to get imaging, they're going to get laboratory tests, they're going to do stuff like that. That is what the primary care physician is there for. They're to screen out medical conditions that are dangerous to you right now, and then everything else, they can prescribe medication, they can give you a little bit of time, and most of that stuff levels out pretty well. But now he's come in, he's got his baseline images, the x-rays are fine. He comes in for that second 6-week follow-up. It's still not better. Now what are we going to do? At that point, they're probably going to order an MRI. They're probably going to order an MRI because, well, we're just going to see what's going on. Why do we do the MRI at that point? Because at this point, you have to understand that there has not been a thorough evaluation of this particular shoulder. So we're operating on just the, for the most part, the clinical sign that he has pain in his shoulder. So now we order an MRI, but what is the MRI there for? Is it for the physician or for the patient to know exactly what's going on? Or is it there to generate a referral? It's there to generate the referral, because at this point, with 2 successive 6-week period of rest and medication management, activity modification, because we told him to just rest, at this point now it's still not better, so this is going to require referral to another provider. So being either physical therapy, orthopedics, or something like that. Orthopedics especially usually will not take a patient that has not had advanced imaging, because what do orthopedic surgeons do?
Surgery.
They do surgery. They want to know if they're going to do surgery, they want to know what they're going to be doing surgery on. Now, he has an MRI. The MRI comes back and it's relatively clean. He still has a referral to orthopedics. Whenever he goes to orthopedics, who is he likely to see? Is he likely to see the surgeon, or is he likely to see an intermediate provider that works with the surgeon, so a nurse practitioner or a PA?
Intermediate?
Well, if he doesn't have something that's overtly surgical, what's likely to happen is he's going to see a PA. And he comes in and sees the PA. The PA doesn't have anything overt to treat, so what is going to be the recommendation at that point? And most people can answer this because they've been through this before. So you've started at the PCM, you've had 2 periods of rest, you've had imaging, the imaging has come back clean, so you're no closer to an answer than you were at the very beginning. Now you've gone to a subspecialist, to orthopedics. There's nothing for them to cut on, so then what does the PA do? Well, he kind of comes in and he'll either send you to PT, or he'll do a shot if he thinks that there's something to inject, or he'll give you guidance. And what is that guidance typically going to be? Rest. Or maybe at this point they're just going to tell you, well, nobody really needs to push weight overhead anyways. And so you get through all of that. Now there's nobody else for you to go see. It's not a surgical case. They're not going to refer you to another level provider. Now you just kind of sit in purgatory right there, because your shoulders know better. You've had this extended period of time where you have not been able to train or whatever. You've had this extended period of rest and you're still not any better. That is, unfortunately, the roadmap for the overwhelming majority of people who go into the American medical system for a minor musculoskeletal injury. And I can just look around the room and there's a lot of people nodding their head, which to me that says most people in here have been down that exact road before. And that's one of the hardest places to be in the American medical system, is to enter in because of an unpleasant experience, so pain, that interrupts your ability to do things that are important to you, but then you go through multiple levels or multiple tiers of the system and no closer to an answer than you were whenever you started. Now, what happens whenever you come in with something like low back pain? So let's take something that's even a little bit more troubling for most people than shoulder pain. What happens? You go to your primary care doctor, and then maybe what do they do? Well, because it's back pain, you're probably likely to get Tylenol or NSAIDs, and you're going to get a muscle relaxer, because that's considered frontline treatment. You come in, you're assessed. They don't really do anything other than that. But okay, let me backtrack just a little bit. It's not that they don't do anything. I need to make that clear. I said that's not how I meant that. They are assessing you for medical red flags. They're assessing you for some type of sign that says that this is a severe issue with your back that requires further investigation right now. They've done that. They just do it in the background while they're talking to you and while they're doing their exam and stuff like that. So that's definitely something that they're doing. But you have nonspecific low back pain. You come in, you're seen, and you get basically the same thing. They may throw a muscle relaxer on there. They may give you some Tylenol, give you some ibuprofen, and then what are they going to do? Well, you know what? Just take it easy for 6 weeks. Just take it easy for 6 weeks. You come back at 6 weeks, and then what are they going to do? They're probably going to tell you exactly the same thing. You know what? Just a little bit longer. Just a little bit longer. Take 6 weeks and then come back. Why do they wait 3 months before they do any imaging?
Insurance. Usually it goes away.
Most of the time it will go away. That's number one. Number two is because there are measures of healthcare effectiveness called HEDIS scores, and an organization gets dinged whenever on their HEDIS scores whenever they image a low back prior to 3 months of symptoms. So your management is largely dictated by what insurance companies and what outcomes are driving healthcare decisions. They're going to wait 3 months before they image you unless you have something that's more troubling. So you had trauma to your back, you got hit by a car or something like that, right? But in a case where it's just kind of non-specific back pain, you have to wait 3 months before somebody's going to image you, because they get dinged on their reimbursement through their HEDIS scores if they image before that without a compelling reason to image. And then there's something else too. What do you think happens to somebody's, especially like in our age demographic, maybe not y'all's, y'all are still a little young for that, but what do you think's going to happen whenever they image my back or Scott's back or John's back?
They're gonna find something.
They're going to find something because I'm over 40 years old. The overwhelming majority of people my age are going to have findings, but what does it do to, and it reliably shown in the literature, what reliably happens as soon as you image somebody's back? Their outcomes get worse because you walk in, I walk in as a 41-year-old man, still relatively athletic, still pretty strong. I have some back pain. I go into my primary care doctor 3 months later. I'm still having back pain. They take a lumbar spine panel, and what are they going to find? They're going to find that I have degenerative changes in my spine, just the same as I have gray hair in my beard, right? Now, depending on how they communicate that to somebody, determines how somebody's going to take that. I walk in with a little bit of back pain. It's just been bothering me a little bit, but I walk in there, and would it seem implausible for anybody in here to have a primary care doctor say, well, obviously your back hurts, you have the back of a 65-year-old man. You hear people talk about that type of language from doctors all the time. What is likely to happen to me if I'm not somebody who kind of knows the system and knows low back pain and stuff like that? How am I likely going to take that?
You're gonna cut back.
I'm gonna take it as now I have to move like I'm a 65-year-old instead of a 41-year-old. All right? Now, advanced imaging, so MRI, CT scan, and things like that for musculoskeletal conditions are most often and most appropriately used as a surgical localizer. So whenever it looks like you have something that should require or may require surgery to correct, that's whenever they will jump to that. In the absence of using it as a surgical localizer to say, hey, this biceps tendon is deteriorated to the point that it needs to be surgically fixated or whatever, outside of that, a lot of primary care providers, like first-line providers, will use it simply as a way to just eliminate the diagnostic process. So what they'll do is they'll just image it. At our age, most of us in here are going to have abnormal findings in just about every joint that you image. So at 40 years old, I have a little bit of arthritis in my knee. Doesn't affect me too much at all. But if I have knee pain that's been recalcitrant or just kind of keeps coming back and it's not getting better, even with the frontline treatments, then what happens is they've now ruled out that there's anything severely wrong with my knee that doesn't require surgery or anything like that. Now for expectation management, they do the imaging to then be able to tell me, you have arthritis in your knee, it's just going to get worse over time, and this is just your new normal. Because then what does that do? Well, now people have some closure. They say, well, my knee is just what it is. There's nothing I can do for it. And then they stop seeking care for that particular problem because it's easy to bash primary care doctors on things like this and say, well, maybe they're not doing things exactly the right way. But in fact, they're doing the only way that they can make it because they have such a burden on the number of people that they have to see. And every single patient that comes in, they have to make the right and the most safe decision for that patient. And so a lot of times, that's why we get the advice that we get, the recommendation, we'll just rest it. For the most part, there's not a whole lot of threat with just take some time off, all right? Now, has anybody heard the term evidence-based practice? So there's considered three pillars of evidence-based practice. So number one is the best available literature, the best available data, all right? Number two, clinical expertise. Because the evidence doesn't learn as fast as a particular provider, and providers are very good at seeing things and noticing patterns and being able to recognize things that we don't necessarily have to have a study that says this particular diagnostic procedure is best for this, because in the process of being a doctor, you've done these tests and you've learned over time that whenever somebody comes in with this particular thing, this is the best thing that you've learned to do with them. And then the evidence tends to support that. But almost as importantly as those other two pillars, what's the third pillar of evidence-based practice? And this is the part that kind of uniformly gets forgotten. And everybody in here needs to know this, because this is every bit as important as clinical expertise and the best available literature, the best available data.
Is it the facility?
Nope. Nope. That's a great guess, though. Patient values. Your values as a patient is the third pillar, the third pillar of evidence-based practice. In order for a provider to practice evidence-based medicine, your values as a patient has to be given equal weighting and equal footing as the best available literature and their clinical expertise. So why is that important for our particular population here? Presumably, everybody is in here because they have some relationship to the starting strength gym, to the starting strength method, or just more generally, that everybody in here at least does strength training in some form or fashion, and that it's important enough for you to show up here to try to learn more about that, right? So can a practitioner truly practice evidence-based medicine if you come in with back pain, shoulder pain, or something like that, and I say, there is no reason for you to press overhead, even though that's important to you? That is an activity of daily living for you. That is something that you identify with. That's part of what you do. That is important to you. Is it truly evidence-based practice for me to say, there's no reason for you to do that?
Them's fighting words.
Yes. I mean, me personally, I dislike the press. It's my least favorite of all the lifts, but I still do it. But that's a question for everybody in here. Can a provider actually practice evidence-based medicine if your values and what's important to you as a patient is not being given equal footing to their knowledge and what the literature says? They can still be an effective provider, don't get me wrong. They can still be an effective provider because they can still get you the right treatment, they can still get you the right imaging, they can still do all of that. But you cannot consider yourself an evidence-based practitioner if you're not paying attention to the patient values. Now, why is that important for this particular population? We all ascribe to a method of training that is very strongly supported in the literature. There's lots of exercise science literature, medical literature that says that what we are doing in the gyms from a rehab standpoint, from a quality of life standpoint, from a general health standpoint, is things are moving in this direction to where progressive resistance training is going to be overtaking cardiovascular training or aerobic training as the preferred type of physical fitness pursuit of individuals over the age of 35 to 40. We're probably about 5 to 10 years from that actually being the recommendation. We're just doing it much sooner than everybody else is because remember, like I said, evidence does not follow it. Evidence always lags behind practice. All right? Now, why is it important for us whenever we go in and we see a provider that we know that evidence-based practice requires that the provider take into account our values?
You can advocate for yourself then.
Absolutely, because in order for you to be a conscientious consumer of healthcare, especially if you want to be a consumer of evidence-based care, you have to be able to advocate for yourself. And if you are in a position where you're seeing a provider who is not willing to take into account your values, now that doesn't mean that they have to acquiesce to everything that you want. By no means should anybody take that as you should go in and tell a provider, I want this, I want this, I want this. That's not what we're talking about. We're talking about things that are important to you, things that kind of define you, your value set. We have to be cognizant of that. And we have to make our decisions with that given equal footing there. But whenever you go in and you see a provider and that provider is not willing to kind of meet you where you're at and come up with a plan of care or a treatment strategy that meets you where you are, then what should you do? At that point, you should actually find another provider. If the provider is not willing to meet you there, have a collegial discussion with them like, hey, this is something that's really important to me and I want to continue doing this. And if they're not willing to to help you with that, then you probably should find another provider, because I promise you that they're out there. Now, here's a big question too. Does a medical provider have authority over you?
No.
Does everybody really believe that?
If you're allowed.
I hope so. I hope everybody believes that. But how many people, and it doesn't necessarily have to be yourself, but all of us have been around people who have been injured, people who have had a diagnosis or whatever, and how many people have come in or just in conversation said, I can't do that because my doctor said I can't do that.
Oh, yes. A lot of people say that.
So maybe it's not in this particular setting as much as it is in the general population, but the overwhelming majority of people believe that medical providers have a place of authority over you. So me as a physical therapist, one of the most common questions I get asked is, what can I not do? And it always kind of takes me aback whenever somebody asks me that. And I'm like, that's not for me to tell you that. That's not for me to tell you that. Now, in some instances, like post-op and stuff like that, there are restrictions that you don't do this for a period of time. But me telling you you shouldn't do that or you can't do that, that should never come out of my mouth unless there is a very strong argument for that. That I should be able to make a very strong argument that you should not do that. If you come in with a femoral neck stress fracture and I say you should not be walking on that leg, I'm going to put you in a protected weight-bearing status. That's because I'm trying to give you medical guidance to prevent you from fracturing through your femoral neck. That's a horrible injury, so that's why I use that one. But I do not have authority over you. In fact, the way that you should look at a medical provider is a consultant. That I operate as a consultant. You come into my clinic to get my expertise and my recommendations to you, but it is up to you to take my recommendations or the recommendations of your primary care doctor, your orthopedic surgeon. You take those recommendations and then you make educated decisions of your own healthcare decisions, all right? None of us should have this air of authority over you where we force you to do something that you don't want to do. The problem with our system is that our system, because it's such a flow from one stage to the next, that what happens a lot of times is once people enter into the medical system, they just kind of start floating down that path. And then before they know it, they're on the operating room table and they're thinking to themselves, how did I even get here? You know, because you go to your primary care doctor, you come back for that follow-up, they order x-rays, you come back, they order the MRI comes back, the provider looks at it, says, hey, I'm sending you to orthopedics. They send the referral to the orthopedic clinic calls you, schedules your appointment. You come in, you see the orthopedic surgeon says, hey, you have a partial tear of your supraspinatus tendon, it's greater than 50%. We need to get you into surgery. So I've got an open date on August 17th. So I'm gonna put you down for August 17th. And you're sitting there trying to take in all this information and everything that goes into the experience of receiving a diagnosis and a treatment plan. You're trying to process this all at one time. And at the same time, they're scheduling you for surgery. And the next thing you know, you show up for surgery and you're like, how did this even happen, right? It happens all the time. Like I see people come in for their first post-op appointment and I ask them like, hey, you know, what was going on prior to surgery? And they're like, I have no idea how I ended up there. Like it wasn't really that bad. And the next thing you know, I'm having surgery. And the reason being is because there's such a push. And it's not that it's malicious in intent, it's just that that's how the system operates, that you enter in and then there's steps along the way there's these thresholds that have to be breached. Once you breach that opens up that follow-on course of care or that expansion of services. So now they put in the referral to orthopedics. You go to orthopedics, the orthopedic surgeon is going to look at that because even more so than your primary care doctor, your orthopedic surgeon could make $15,000 doing surgery, or they could make $25 by doing a 25-minute evaluation on you. And so most of them, it's not financially or economically viable for them to sit there and talk with you for an hour and a half to find out what the genesis of your symptoms were, how the progression has been over time, have you made any modifications to your training, nothing like that. You come in, you have a torn supraspinatus, I can repair that. I'm going to have you sign a form that says that you agree that this surgery may not improve your pain. It could make your pain worse. Oh, it could cause bleeding, infection, and death, and you're going to sign your name on that. You go off to surgery. Overwhelming majority of the time you come out of surgery and you're just fine. But if you don't get better from surgery, who now owns that? You as the patient, because you signed away saying that you understood that this may not help your pain. All right. So is there any part of that, and I know that it's a little bit of a caricature, and please understand that that's for illustration purposes at all. I want everybody to know I am not saying that primary care managers are at fault, that they're terrible people, that they're malicious in intent. What I'm saying is that they are constrained by a system that forces them to have to see a lot of patients per day. They have to see a lot of patients per day, constrained by the rules and the limitations of their insurance company, Center for Medicaid and Medicare Services. And there's a lot of outside entities that say this is how you're going to practice and this is how your decision making is going to be. There's a few places out there that have gone to outcome-based medicine. Outcome-based medicine is probably the next horizon, that if we could move to that being more standard, that means we are going to incentivize you, being an orthopedic surgeon, whenever your patients get better. You're a terrible orthopedic surgeon, your patients are not getting better, we're actually going to penalize you with your reimbursement by giving you less money because your patients aren't getting better, your patients are getting better. We're going to incentivize you by giving you more money to do that, and we're going to push more patients towards the people that get better outcomes. Now, is that going to take over the entire system? No, it's not going to. Now, that's the medical system. Now let's add another layer into this, something that I am intimately familiar with. Musculoskeletal injury. Before you get to orthopedic surgery, who are you going to go see?
Physical therapist.
You are going to go see physical therapy, right? Now, you are not going to hurt my feelings at all. How many individuals in here, by show of hands, if you feel comfortable doing that, have been to a physical therapist? How many people have been resoundingly satisfied with their care at a physical therapist's office? Less than half. Less than half. How many people went for a particular ailment that was not post-op? So not somebody who had surgery going, but somebody who went for low back pain, shoulder pain, knee pain, something like that did not require surgery. How many people were very, very satisfied with the care and the results that they got from physical therapy? It's less. It's less. Why is it that physical therapy does not work for the majority of people? Historically, and in the literature, we expect about a 40% of patients going into physical therapy have a good outcome. The overwhelming majority of people actually have no true change to their symptoms that is not already explained by natural progression of the injury or the ailment. So people with shoulder pain, guess what? At 18 months, your shoulder is going to feel better. Whether you have physical therapy or not. If you had adhesive capsulitis or frozen shoulder, at a year to 18 months, your shoulder is going to feel better whether you went to physical therapy or not. All right? But why is physical therapy, especially in this population in the room, not as effective as it should be? It is absolutely way too conservative. Now, what if I were to tell you that, I'm sure somebody in here, don't raise your hand, but does somebody in here have like persistent headaches? They just have headaches like pretty frequently, and Tylenol for the most part is an effective treatment for most headaches. What if I were to tell you like a normal dose of Tylenol is 325 milligrams or 500 milligrams of Tylenol is an extra strength Tylenol? What if I told you instead of 325 milligrams of Tylenol, what I'm going to say is I'm going to give you 5 milligrams of Tylenol, but the reason why I'm doing this is because I'm going to give you just enough of it for your body to take over itself. What does that sound like? Has anybody ever heard the term homeopathy or homeopathy? So homeopathy is this like kind of complementary and like alternative medicine type thing where they take very minute amounts of a particular medication or substance and they give this to you in this very, very diluted form because it's not regulated whenever it's diluted that much. But the idea is that if I give you a little bit, like trace amounts of human growth hormone, that's going to cause your body to produce more growth hormone. It's going to stimulate your body to do that. Physical therapy, by and large, is akin to a homeopathic dose of exercise for most people, especially in this room. Physical therapy as a profession was built on how you treat, say, the lowest common denominator. And the lowest common denominator would be the individuals that are the least able to do physical activity. So somebody has shoulder pain, and let's say who in here has a pretty decent bench press or shoulder press? All right. So you come in. How much is your bench press, shoulder press? Just throw a number out there.
Mine for
Yep.
regular sets.
Yes.
What? He's done 200 overhead press.
Okay, 200 overhead press. So he comes in and he has some pain with his shoulder. Let's say your right shoulder. You come into physical therapy. What do you think they're going to give you? What exercises do you think they're going to give you? Every single shoulder patient in the world is going to get TheraBand-resisted internal and external rotation. You're going to sit there and you're going to grab a TheraBand and you're going to pull out like this, and then you're going to pull in like this. You're going to do it like this, right? Now, in somebody who presses 200 pounds overhead, can we reasonably expect that that is going to be enough of a positive adaptive stress or mechanical stress on his shoulder to make it better?
No.
Absolutely not. And I would actually tell you that anybody in this room that has trained more than a couple of weeks, you are going to get a homeopathic dose of activity or exercise whenever you go into a physical therapist, because physical therapy as a profession is geared for people who don't pursue regular strength training. It is there for people that, whenever I say lowest common denominator, physical therapy as a profession, as it's practiced across most physical therapy clinics in the United States, is for sedentary people. So someone who has not ever trained, has never pressed overhead, has never gone to the gym 3 times a week and done a novice linear progression, and somebody who just works an IT job, they sit at their desk for 8 to 9 hours a day. They go home, they have their favorite show on Netflix that they watch, they eat dinner, they go to bed, and they repeat the next day. In that particular case, someone who does not do any dedicated physical activity, internal and external rotation with a TheraBand is probably enough of a positive adaptive stress or mechanical strain on that shoulder to cause a positive effect. But in our population, you see that the number of people who were very, very satisfied with their care is less than 40%. And the reason being is because most of you individuals in here have already graduated out of what physical therapy could do for you for a traditional just musculoskeletal injury, not taking into account post-operative care. I have to say this, anybody who has gone through orthopedic surgery, neurosurgery, orthospine, something like that, you do need to go to physical therapy. You do need to do that. That is actually very strongly supported in the literature. You need to do physical therapy. Outcomes are far better for people who do it than people who don't. For normal routine musculoskeletal injuries, it is actually, the outcomes are exactly the same whether you go to therapy or you don't. The only thing that has been shown reliably to be improved by traditional physical therapy is the time that it takes for you to get better is slightly less whenever you go to physical therapy. But if we dive into that number just a little bit, who makes up the overwhelming majority of the individuals that they are studying in these populations for these studies? It's sedentary people. So one thing that, as much as it pains me to see, is to say this, the physical therapy profession is not geared for most people in this room. physical therapy is going to be, for the most part, outside of a few things that we do really well, it's probably going to be a bit of a disappointment for you whenever you come in. And the reason being, you've graduated out of physical therapy because you're already too strong for a traditional physical therapy clinic to be of any benefit to you. Now, if you go to a good physical therapist, so somebody who has the ability to kind of meet you where you are, what do you think physical therapy should look like? And I'll save everybody the suspense. I'm not going to say everybody should squat, everybody should overhead press, everybody should have barbells or anything like that. But from a more philosophical standpoint, what should physical therapy look like? Has everybody seen the stress recovery adaptation model? I know somebody has. So she's going to see it. She's going to see it again. All right. So what's that, Scott? Yes. This is really, if you can understand this, if this will make sense to you, this serves as the absolute foundation of everything that you need to know whenever it comes to managing your own injuries that are capable of being managed by yourself, okay? We're just gonna take the typical stress recovery adaptation model and we're just gonna add a couple of pieces to it, make it a little bit more complex. And whenever you see this, you'll be able to say, okay, this makes sense to me. All right, so whenever we look at the stress recovery adaptation model, what most of us are familiar with, can everybody see that? I'm kind of outside of the pillar here.
Can you use the purple?
What's that? Can I use the purple?
Or pink? I'm getting the purple charger.
Only because you want purple. Bree gets whatever she wants.
Yeah.
Okay, so stress recovery adaptation. Does everybody know where stress recovery adaptation came from? It's one of the most cited studies that I've been able to find. It came out, I believe, in the 1950s. There was a researcher named Hans Selye, and what he did was it was either lab rats, lab mice, one of the two, but he subjected these rats or these mice to a lot of different types of stressors: electrical stress, chemical stress, poison stress, exercise stress, and what he found was that no matter what the stress was, the animals responded generally the same exact way. What they did was whenever they were exposed to a stress, the body went through an alarm phase. Then after the alarm phase kind of regulated, then they went into like almost like a fight back stage. And then what they ended up doing after that stress had been removed is they adapted to that level of stress to where they were more tolerant of that stress over time. Anybody who has ever dealt with alcoholics, drug addicts, people who go to tanning beds, people who played The Legend of Zelda whenever they were kids, have all seen this. What happens, an alcoholic does not start off drinking 36 beers in a day. They don't. What happened? They started with one or two. One or two turned to 2 to 3. Because whenever they first had that first beer, 1 to 2 beers was enough for them to go through an alarm phase where they feel buzzed, they feel drunk, whatever. But over time, they developed a defense mechanism, so to speak, to where they were able to tolerate more and more of that. People who played The Legend of Zelda, you start out with the little wooden sword and the little wooden shield, and as you fought more and more of these little like gumdrop looking things, you got stronger and stronger over time. Stress, recovery, adaptation, but that happens generally with everything. People who go to tanning beds, they go to a tanning bed, the first time they're in there for 3 minutes and they get sunburned horribly, right? 3 months later, they're not in there for 3 minutes, right? At that point, now they're in there for 20, 25 minutes, something like that, because their body has become accustomed to that. Their body has now been able to take more and more of that stress because it's adapted to make itself more tolerant to that particular type of stress. And that happens generally, so Hans Selye called it the general adaptation syndrome. Now, what happens if you take a stress and you give way too much of that stress at one time? What's the end result of virtually any stress taken to the umpteenth degree?
Injury. Death.
Death. death, right? What happens whenever somebody drinks to the nth degree? They can actually die from that. What happens if somebody were to get into a tanning bed and stay in there for hours and hours and hours? Potentially, the person could actually succumb to the stress of that, right? So whenever you're looking at this right here, this is death. That amount of stress is too much for the organism to take. So you have death right here. Now, before that, somewhere quite a ways above this, since we're talking mostly musculoskeletal stuff, we're going to call this tissue threshold. Now, again, somebody has already seen this before, but let's take somebody who is a dancer. Somebody who's a dancer, and they're doing a movement where they're basically kicking their leg up as high as it can go. Whenever they kick their leg up like that, what tissue is being strained more than anything else? The hamstring, especially the proximal hamstring, right? So think of this in terms of nanoseconds. We're going to start with a particular stress, and then as that leg comes up higher and higher, there is more of a stress being applied to that instantaneously, right? We're talking every nanosecond, there's a little more strain on that tissue. But whenever you look at it as somebody do the whole movement, it happens that fast, right? So it's almost an instantaneous strain, but we have to look at it in like nanoseconds, break it up into small pieces to then start to understand that the strain on that tissue is happening more and more and more and more and more. As that leg continues to come up more and more and more, there's more strain on it. Now, this particular person is kicked overhead potentially hundreds of thousands of times, and they didn't have a hamstring strain before that. But this particular time, they put this strain on the hamstring, and then they get to this point right here. Now there's enough strain on that a nanosecond before, the tissue hadn't failed yet. At this particular instant, there is now enough strain on that tissue to now the tissue starts to fail. Same thing happens in ankle sprains. How many people have rolled their ankle and then walked it off and they're totally fine? It happens all the time. You put a strain on it, instantaneous strain, but not enough to get to the point where the tissue fails. Now you step off of a curb really hard and your whole foot turns inward and you rupture that ligament. That strain instantaneously was enough to take you past tissue threshold, and that tissue fails. It tears. Now in this particular situation, person kicks overhead. At this point now the tissue has actually torn. So now once they hit that point, the tissue starts to fail. The tissue separates, the tissue tears. Now they've got a torn hamstring. Immediately afterwards, how does this person feel? They feel like, oh no, oh no. They know immediately that something went wrong. But do they feel better here, or do they feel better 3 hours later? Or 4 hours later?
I feel better now.
The overwhelming majority of the time, they are going to feel much worse in a couple of hours, right? So even though we took the mechanical strain away from it because the mechanical strain was applied, it tore, there's no more mechanical strain on it at all. The tissue now in the immediate inflammatory response is going to degrade the tissue even more. So as soon as it happens, you'll see it, people can kind of hobble like this. They're walking weird. The very next day, they are completely unable to put any weight on it whatsoever. They are worse off today than they were whenever it first happened, okay? Natural consequence of the inflammatory process and the body's ability to process pain signals acutely and what happens over time. Your body does not make modifications to something like this immediately. It takes several hours for the brain to say, you've gone and done it, and I'm not going to let you put any weight on that. Okay, but then what happens, let's say 2 weeks later? How does this person feel 2 weeks later? They've probably been walking with crutches at this point for about 2 to 3 weeks or so. But then what happens? Now all of a sudden they can walk without crutches. maybe they're walking slow, but they can walk without crutches. They don't need that support anymore. So they've actually gotten a little bit better, but if they move just the wrong way, it still hurts. So they haven't recovered past tissue threshold just yet. Now let's fast forward from initial injury 6 weeks into the future, which is the typical tissue healing timeline, give or take a week or so. This person is healed, and now they're here. Now they can walk just fine. They're not limping anymore. They don't have a whole lot of pain anymore. Maybe whenever they do certain movements, they'll still feel something, but now they're above tissue threshold. Whenever you go into physical therapy at this point, what do we do? Well, for the traditional physical therapy approach for this is actually we're going to do stretching. We're going to stretch this hamstring. All right. It's a little bit of a stress unless we push you too far, and then guess what we just did? We actually just tore it again, right? But what's going to happen, we're going to put a small stress on it, and it's going to get a little bit better. And then you're going to find a place, probably somewhere in here, where that's as good as you're going to get. All right? Because there has not been a continuous application of stress to make it adapt to where it got better. Okay, so in stress recovery adaptation for acute injuries, this is what happens. Now, this is in one instant in time, tissue failed. You know exactly when that happened. Someone who's torn their ACL, someone who's torn their hamstring, they could probably tell you everything leading up to the millisecond whenever that happened. They could tell you their foot position, they could tell you what they were doing. Does this sound like what most injuries in the gym seem like? For the most part, no. Most of them are more insidious in nature, right? It just kind of creeps on over time. There was an individual today that fractured his forearm squatting, had a squat mishap and fractured, not his forearm, his humerus. I can guarantee you that person knows exactly when tissue failed, all right? Now, this is not what happens, but about 10 to 15% of the injuries that come into a physical therapy clinic are acute injuries. These are relatively easy to treat because we know exactly what happened. We can get you to about right here in a physical therapy clinic, which is still above tissue threshold, and most people who are sedentary are totally fine living right here. But that's not what happens with most injuries. What happens with most injuries? Has anybody heard the term overuse injury? Okay, typically whenever you go into a primary care doctor or something like that and you'd say, hey, I've been lifting for 6 months or something like that, my shoulder's starting to bother me, they're going to tell you it's likely overuse. What does overuse mean? Well, you're doing things too much, right? In some circumstances, overuse is the actual mechanism of injury, but in most cases it's not. If you take your normal baseline, which is, we'll just template it right there, and you can use any metric that you want to for this. You could use your 1 rep max bench press, you could use your 2 mile run time, you could use how many crunches you can do in 3 minutes, whatever physical marker that you want to use, because you've got 4 billion of these working at one particular time in your body. But let's say your overhead press, that you are able to press 200 pounds overhead. You go into the gym, and what we hope happens with the stress recovery adaptation is we apply a stress through training, that we give you a proper period of recovery, and then whenever you finish recovering and remodeling from that particular session, that you're slightly better than you were before you did it. And then over time, you have a whole bunch of these, and if you're a good trainee and you keep records of what you do, like if you have a place at the front of the gym with a logbook and you write down everything that you do, and you look over time, your 200-pound press is now 235 pounds. You have objective data that you have gotten stronger, and it's this mechanism that is happening. What happens if you decide, I really want to drive my press up right now, so I'm going to start pressing every single day? And oh, by the way, because everybody wants to do this, instead of doing 3 sets of 5, I'm going to do 5 sets of 10, because I'm going to do some high volume hypertrophy work, right? So then what ends up happening? You apply a stress to the tissue, you have incomplete recovery, and then you stress it again. and you do this. Now, what is this going to look like over time? That now all of a sudden your 200-pound press that you were doing just fine, now all of a sudden, now it's 175 and you're starting to struggle. And you're starting to grind through weights that you were able to do as a warm-up before. This is a decent indication that you are overtraining. This is an overuse injury waiting to happen. The only thing that separates overtraining from overuse injury is once you've deteriorated enough to the point where you cross tissue threshold. So now either the tissue starts to fail or the nervous system starts to give you alarm signals that you are not recovering. All right? This actually does not happen that often. It does, especially in gyms like the starting strength gym. You can see this happen, but I'm going to posit a hypothesis to you guys, a more likely cause for the vast majority of people having injuries that occur over time that is not overuse. So I'm going to kind of erase this, redraw it because it's starting to get messy. Had conversations with people or been on Facebook groups or something like that, this will immediately resonate with you that, yep, you see this all the time. Just maybe nobody has articulated it like this. So we draw the same thing, stress recovery adaptation. This is your baseline. This is tissue threshold. You start with a 200-pound press. And then for whatever reason, life gets in the way. You decide that you're going to take a break from training, whether it's an injury, you're traveling, whatever, but you take a long break from training. What happens to your baseline over time? It decreases over time. All right? Now, you decide, and this has gone on for a long period of time, and then you decide, well, I really need to get back into the gym. And I look back at my logbook because it's still there at the entrance to Starting Strength Memphis. You look at your logbook and you're like, okay, I was pressing 200, so I can't press 200. I start my warm up. I'm doing 135, but you know what? Instead of doing 5s, I'm going to do 8s because I need to get myself back to where I was. So now you're here. Your baseline is here. The reason why you have had this decrease in performance over time is the adaptations you made to get here, you have started to lose those adaptations. And this is particularly supported by the literature that people who go through a progressive resistance training program before being put on another program. So you take two groups of people, let's say we put them on a running protocol. But we take one group and take them through a progressive resistance training program for 6 weeks, 6 to 8 weeks. The other group, we don't do anything with them for 6 to 8 weeks, and then we put them on the same running protocol. What is the injury risk reduction for people who went through 6 weeks of resistance training? Reliably, in multiple studies, multiple methods, but they all say about the same thing. The injury risk reduction is somewhere between 65 to 80%. People who have gone through even just a 6-week program of strength training have, in some studies, an 80% reduction in injuries compared to people who don't do that first. And this is the reason being. While those people are doing a 6-week program and they're getting stronger, their baseline is improving. The people who are not doing that, even if they haven't been doing anything up to that point, 6 more weeks of time means that their baseline is going to continue to deteriorate. Whenever that happens over a long period of time and your baseline is down here, look how much closer to tissue threshold you are than whenever you've done a progressive resistance training program. You're much closer to tissue threshold. So you decide to do your couch to 5K program, but you haven't run in 45 years. And then you decide, well, you know what, I want to do this race in 6 weeks. So that means instead of doing twice this week, I'm going to do 6 times this week because I need to get a lot of this in. Third time running, you've crossed tissue threshold and now your knees are screaming at you, right? You go to the doctor and the doctor is likely to tell you what?
You can't run.
They'll tell you to rest, which then does what to your baseline?
Increases.
Your baseline is going to decrease. So if we take this period right here, we move it back over here just so it can be on the graph. You've crossed tissue threshold. What happens with that 6 weeks of rest?
Goes down.
Well, what's going to happen is you're going to have a little bit of recovery. The tissue is going to feel better because you're not stressing it, right? So you're going to have a recovery period. But once you get through that recovery period, then what happens? Your baseline is going to start to go down again. So then you've taken 6 weeks away from running, and you go to run again, and what happens that first or second time that you run? You cross tissue threshold again. So then you go back to your doctor and you say, and please understand, physical therapists are just as bad at this than physicians. So I'm not trying to say that like we're really good at this. We do this horribly in most parts of the United States. So you've taken 6 weeks away from running, you start running again, and guess what? Your knee hurts again. What's the doctor likely to tell you? Well, you just didn't take enough time. So you've crossed tissue threshold, you get some symptomatic relief through Tylenol, ibuprofen, whatever, and then you take 3 months of rest. And then what happens? You start to run again, and your knee hurts again because you've deteriorated again, close to the point of tissue threshold. So you run the first, second, third time, your knee starts to hurt again. It's just as bad as it was before you did all this. You go back to your physician, they order x-rays, MRI, there's nothing that they can see that's surgical in your knee. What are they likely to tell you at this point?
You're not going to go running.
Stop running. You're just not a runner anymore. You're 35 years old. You don't need to run anymore, okay? It is a misapplication of the overuse model of injury to put it's misapplied as an overuse injury in the setting of someone that this is a detraining injury. And whenever you treat these exactly the same, this is the end state that you get. Now, everybody in here, for the most part, has gone through at least a portion of a novice linear progression, correct? What is the defining characteristic of a novice linear progression?
Adding 5 pounds.
Adding 5 pounds.
Gains all the time.
Yeah, for as long as they happen, and then at some point the magic train stops, and then things start to get pretty terrible, and you're grinding through workouts, but at that point, you've committed to it, and you love it at that point. But the novice linear progression starts with a very small stress. Because we start you at a weight that you can handle just fine. You do 3 sets of 5, you're not overly fatigued whenever you finish it, you're not grinding out repetitions, you're not trying to find ways to compensate to just get through that rep. And then because it's a low stress impulse, you don't have to recover very long. 2 days and you're back at it again. And then we're gonna do it, and we're gonna do it again, and we're gonna do it again, and you're gonna do this. Now what happens now? You started back 85 pounds on a bench press. Now at this point, it's 155 pounds. What does the stress impulse on bench press look like now? Now it's starting to become more pronounced, so you have to take more time away from benching. So at that point, maybe you're bench pressing once a week, maybe you're splitting it into 2 one week and then 1 the next week, because now we're taking bigger recovery periods. Or at this point, we're doing a day that's higher volume, a day that's higher intensity, but we're gonna start managing your stress impulse based off of your ability to recover. Now, in the setting of an injury, can everybody see that if you're at this point right here, that whether it be an overuse injury, whether it be a detraining injury or anything like that, but tissue threshold, you've gotten to the point where you can move the way that you want to move. What gives us a good way of getting back from here? Maybe giving yourself a small stress compared to what you've been able to do before and increasing it over time. All right? Now, in this case, if we're looking at this period right here being rehab, what is the goal of rehab? In almost every case, there are certainly cases where you cannot get back to what you've done before. There will come a point in everybody's life where they have hit their last PR on whatever lift it is. They're never going to do more than that again.
No.
It's going to happen. Now, how much you fight against that, that's what people have to, that's what you really have to take stock of. How much are you going to fight against that? But what should the goal of rehab actually be?
Get you back to where you were.
At least there. At least there. All right? In the traditional physical therapy setting, how many people would agree that your physical therapist is treating your rehab to get you back to your baseline versus the rehab approach is trying to get you here to where you're not complaining about it and you can just get by with everyday life? More often than not, this is what you're going to get. Okay. Now, does everybody need a break? Does everybody need to go use the bathroom or anything like that? Everybody want to just continue on?
Yes.
All right, let's continue on. Okay, so now we're in a little bit of a conundrum. The conundrum is that the medical system is not set up for you. It's not at all, because most of the providers don't have any understanding of what you actually do. Go in and tell a normal nurse practitioner, PA, physical therapist that your shoulder hurts after benching 185 pounds, and they're going to recoil in horror that you would subject yourself to such an irresponsible exercise like that. Now, the second layer of this that you have to combat in the medical system is a term called kinesiophobia. And unfortunately, I don't want to get sued, so I am not going to name names, but do most people in here have at least some presence on, or whatever, on Instagram, YouTube, anything like that? Has anybody seen fitness influencers on
No, I don't use Instagram just for that purpose.
Now, what does kinesiophobia mean?
Fear of exercise.
Fear of movement, but in our setting, fear of exercise. What is the defining characteristic that sets in kinesiophobia in somebody?
Pain?
Well, I guess what leads to kinesiophobia, it is the belief that a particular movement is dangerous. The belief that a particular movement is dangerous. Everybody in here has been through a novice linear progression. How many people in here thinks that inherently a squat, a deadlift, an overhead press, a bench press, a chin up, anything like that is inherently dangerous? That it is dangerous and irresponsible for you to do that movement? Not a single person in here, right? Because you've done it and you're just fine. We see people that deadlift almost 1,100 pounds, or 1106 is the world record now. 1,106 pounds. We're actually far more resilient than we would like to think. But if you go in and you tell a physical therapist, a doctor, whatever, that you deadlifted 405 pounds and they recoil in horror, what are they likely to tell you? You shouldn't deadlift, that's dangerous. It's dangerous, it's irresponsible, you shouldn't do that. Now, in a person who has not been through what you guys have been through, what does that then communicate to the patient?
Deadlift equals bad.
Deadlift is bad. You go in and you tell most medical providers that you lift weights. And what do they say?
That's dangerous.
That's dangerous. You shouldn't lift heavy, it's dangerous. Evidence-based practice would tell you that that's not true whatsoever. And in fact, heavier weightlifting is actually safer than higher repetition weightlifting. And it's safer and it's actually more effective whenever you do moderate to high intensity resistance training, and it's safer. But then again, they're managing diabetes, they're managing rheumatoid arthritis, they're managing strep throat, ankle sprains, things like that. They have far more important things to worry about than does resistance training better shoulder pain or not. They just can't know all of that. But the defining characteristic of kinesiophobia is belief that movement equals bad, or an exercise is bad. There is an entire industry in social media right now about that markets off of kinesiophobia. Has anybody seen a particular markets himself as a physical therapist, even though he has not worked in physical therapy for the most part in his entire career? He does almost every single one of his videos shirtless with fake weights, and all of his like thumbnails on his video says something like, avoid this one exercise for shoulder pain, and it shows like a picture of him with the shirt off and like red lightning in the shoulder or something like that. And then they tell you, like, you know, the only thing that's certain in life is you have to do your face pulls, right? People have seen that. And then my absolute favorite is this particular person who I've renamed his particular page Kinesiophobia Community College. This individual has made a very large following and has made a lot of money by convincing you that if you do not move with perfect technique every single time, you are going to be in pain. And then he shows these like videos where he has somebody lay down, and he shows like this little video of like an anatomy app on his phone where it shows like a person moving like this and says, well, here's this muscle and I massage this muscle, and then he can move pain-free. This is a very, very, very prevalent part in the fitness community right now because this is marketable. Because if we can get people to be afraid of movement, then what do we have the answer for?
Their ailments.
Right. That if ordinary movements are bad, who do you then have to rely on?
An expert.
The self-termed expert who knows this better than everybody else. They know that magical exercise to get rid of your shoulder impingement. They know the magical exercise that will keep you from having back pain. And for someone who's been suffering from back pain for a long time, this sounds wonderful. It doesn't sound wonderful to you guys. Why does it not sound wonderful to you guys? That one magic trick that all doctors hate to cure back pain, why does that not sound great for you guys?
It's not doing this program.
Because you live in reality, right? And guess what reality requires is it requires consistency, and it requires a lot of hard work, right? You're not going to get the benefits that you want in the physical realm by not working hard. But people will pay a lot of money for you to give me a solution that doesn't require me to train hard. For the most part, every single influencer, every single video that you see come across your Instagram feed, on your YouTube, that says deadlifts are bad, squats are bad, or this particular movement is bad, is marketing off of this. Your primary care physician, your physical therapist, your orthopedic surgeon who says it is bad to press anything overhead, overhead movements are bad, they are inadvertently ascribing to kinesiophobia as the primary treatment. Instead of let's find a way for you to move so that it doesn't hurt, or let's find a way for you to load this in a manner that you can positively adapt over time to get you farther away from tissue threshold to make you more resilient to injury, let's just get rid of this because this is easy to do. And you have to understand that the overwhelming majority of people in the country want whatever's easy. That's why people click on the little thing on the right side of their Facebook that says that one weird trick that all doctors hate. Like, doctors hate this man for this particular trick that he found. That catches your eye because you want the inside scoop. You want the inside scoop. That's why the supplement industry makes billions of dollars every single year, because you're not moving a whole lot of supplements telling somebody your best supplement is consistency. 10 years of dedicated strength training is going to give you most of the results that you want, not your creatine and HMB product from, Muscle Tech or whatever. That's not the secret. The secret is consistency and stuff. But the reason why consistency works is from a physiological standpoint. That is how your body adapts over time to physical stress. How are we doing on time?
Probably about 10 minutes.
Okay. Now, is there anything that anybody wants me to cover specifically before we break? Or does anybody have any questions?
Can you cover day-to-day like aches and pains, like it's not caused by
Yes,
alarm bells?
actually, that's probably the biggest thing that we should. I meant to do that. All right, so let's give you your roadmap. This is actually exactly what I wanted to talk about. Now I've got to go through it really fast because I don't manage my time well. All right, so here's your roadmap to injuries. So anybody in here, you're in the gym, you pull a deadlift, a rack pull, a squat, whatever, and you feel something go, and you're like, "Out, that did not feel good." Immediately you know that you are not the same right now than you were several nanoseconds ago, all right? What is the first thing and the most important thing that you can do at that point?
Don't freak out.
Yeah. Don't panic.
Don't panic. Don't panic. What happens whenever people panic?
It gets worse.
It's
Gets
bad,
worse, Catastrophe.
People start to catastrophize.
Okay.
I mean, all of us have been injured, right?
Yes.
And like I have to admit, like I had the only moderate to severe back tweak in my life while I was stationed in Korea. Pulling a deadlift that I've done thousands of times was not heavy for me whatsoever. I'd not been sleeping well leading up to that. It was an easy weight, came up off the ground about halfway, and it was like, that did not feel good at all. And guess what I immediately tried to do?
And wait.
Now, what did I do immediately after I tried to do this? I went back and pulled it again. And then at that point, I had to convince myself not to panic because I was starting to do this again, because the second time I pulled it, it felt even worse, right? But catastrophizing, what is catastrophizing? Well, I guess that's the last time I'm ever going to deadlift. Shit, I'm going to have surgery. Oh, God.
Cancer.
Like, I'll never be the same again. Like, this is the end of my lifting career, whatever. You don't panic, because panic causes you to catastrophize. We don't need you to do that. Number two, what do you need to do? We're low on time. Analyze. In your recovery period, sit there and go through your training log. Think back, okay, why did this happen? Was it because I was really, really tired? Maybe I was really tired. Maybe I stacked 2 workouts on top of each other. Something that I am not used to doing, but I did something radically different than what I normally did. Try to find what it was that actually is the most likely cause of the tweak or the injury that you just had. The other part of analyze is, if it is safe, the young guy that broke his humerus on a squat, it is not safe to go ahead and try to do your bench press. But that individual knew that, all right? So there's a difference between varying degrees of injuries, all right? But so whenever you're in the analysis phase, what's something else that you can do? And this is what everybody tries very hard not to do.
Do what you can do.
Try.
Yes. Find out what you can do. There are many different variables to resistance training. There's intensity, how much weight you have on the bar. There's volume, how many times you're doing that throughout the workout. There's how many times you're doing it every set, so your in-set volume. There's time under tension, there's range of motion. There's lots of different things, but what do most people do whenever it hurts whenever they squat? What do they want to do? Stop squatting, right? Part of the analysis phase is it hurts when I squat, but what part of the squat does it hurt? And can I modify that to get me as close to a normal squat as possible, but making enough of a modification to where I can do it comfortably enough that it maintains my consistency? Because what is the secret to rehab and long-term progress in the gym? 95% of it is consistency. All right, so individuals that I worked with today, what were we trying to do? We're trying to find a way for you to get as close to that normal movement as possible in a way that you could do it consistently so that we could start doing what? You've got to start to progress it. What does everybody want to do whenever they have, if they don't just throw the baby out with the bathwater on their squat, it hurts when they squat, so I'm just not squatting anymore. What's the normal thing that you see, Facebook groups and stuff like that? What does everybody tell you to do? Deload and do a whole bunch of reps, or deload and start box squatting or something like that. Let's not do that if we don't have to. All right? What you're going to do is you're going to find out what you can do, and you have to make modifications to your program to keep you training hard, even if that means that you have to take some of the weight away. But if you take some of the weight away, you have to increase the intensity somehow. So maybe you increase time under tension. Do the repetition slower so that you can still produce enough mechanical strain to start to improve. But you don't just deload and throw a whole bunch of repetitions at it. Because if you look at it from the stress recovery adaptation cycle, what is harder on you? A heavy set of 3 or 3 sets of 10 from a recovery standpoint? 3 sets of 10. So what do you do whenever you strip a whole bunch of weight off and then you do a whole bunch of volume?
Make it worse.
Well, you make the stress impulse even bigger, which is more dangerous to you at that point. But then even if you kept it at sets of 3, but you went from a 405 squat to 135 because you can do it comfortably, what is all the days that you squat 135, 140, 145, whatever, what are those? Those are absolutely wasted training days, because that is not enough of a stress impulse for you to be able to adapt to it. So you're going to progress by finding what you can do, what you can substitute for intensity to make things a little bit harder so that you're still training hard, and then you're going to start to progress that over time. All right? Then the last thing that you do is, as you're progressing whatever modifications that you made, you're going to start layering the full movement back into your warm-ups. So maybe I'm doing pin squats, or maybe I'm doing tempo squats or something like that, because I notice that at the bottom of my squat my back hurts. So I substitute a variation of the squat that I can do comfortably but still train hard, and I'm doing my work sets like that. Now what I'm going to do is, as I'm feeling better and the weight has gone up on that particular lift, I'll start doing my warm-ups with a regular squat technique. And then every single time I come into the gym to do that tempo squat or whatever, more and more of my workout is going to be overtaken by the normal squat. And so what rehab should be is, it should be like this. You have rehab, and then you have training. And whenever you do it correctly, rehab just turns into training. It is a seamless transition. There's no, I finished rehab, I finished physical therapy, now I can go back to training. Rehab is nothing more than training at the point that you are, and then as you get closer and closer, now you're just training again. But what does that really mean that rehab is? It's actually just training. And that is how rehab is done correctly. Is that you just take what your capabilities at this time, and the absolute most imperative thing, not panicking, not catastrophizing, analyze what you can do. You're going to progress that over time, trying to turn your rehab back into training. And then outside of that, what's the best thing that you can do?
Consistency.
Consistency. Now, you didn't catastrophize, you're analyzing, you're progressing everything, You're getting back to normal and something happens and you get injured again. Now what do? Go through the exact same thing. Now, at what point should you seek the services of a medical provider? It's really important that everybody understands this. Whenever you feel you need to. Okay? So I can tell you, and I think most of us kind of have this general understanding that maybe it's not as effective as we want it to be, right? But the only person that can determine whether or not you need to see a medical provider is you, all right? But then we go back to the first part of the lecture. You go in and you see a medical provider. What do you need to be able to do for yourself?
Advocate.
You have to be a conscientious consumer of healthcare. You are seeking the services of a consultant. You're getting advice. You're getting guidance from them. But at the end of the day, it's up to you to take their guidance and implement that or not. And that you should always make sure that your healthcare provider meets you where you are as far as your patient values, because it is not evidence-based practice for me to say, I know it's really important for you to lift weights, but nobody should really do that. You know what? Just curl some beans in your kitchen, or go for a jog a couple of times a week, and that's really all the activity you need. That is not the case. They need to meet you where you're at. Now, whenever you kind of understand the stress recovery adaptation model and how you're going to implement this, because what are you doing whenever you implement this? You're progressing,
Yeah.
you're being consistent, you're using an analytical mind to make the best decisions to keep you training. Because the absolute worst thing that you can do, not only for injuries but for quality of life down the road, is find a reason to exit training. Because regardless of who you are, it is almost a universal truth that you have to train. You have to train. No matter what age you are, no matter what your orthopedic condition is, you have to find a way to train. Because the ramifications from a health perspective of not doing deliberate physical exercise the effects of that are going to pale. It's going to make your orthopedic conditions pale in comparison to that. Because what happens to a sedentary body over time?
Deconditioning.
Just look across the typical American population and you'll see what a lifetime of sedentary activity does to a human body. It wreaks havoc on the human body. The only thing that we really have that combats entropy to some degree, entropy just being the law that order turns to disorder. The only thing that we really have that actually combats that is physical activity. Physical activity is the closest thing to reversing entropy that we have. Now, does anybody have any questions?
Was there a, you mentioned on your example about deadlifting 400, you tweaked something, you went down to 135, that's not enough to stress. Is there a percentage that's kind of a sweet spot?
So the percentage is the highest weight that you can do on that lift, and you can move according to the way that you desire to move. Because even in an acute injury, after 2 to 3 days, you're back in the gym and you're training again, you want to put as heavy a load on that as you can that you're able to move in the way that you want to. And a good baseline to keep in mind whenever you're training through something like that is injuries hurt. And whenever you train an injury that hurts, it's going to hurt while you're doing the movement. But if you get done with the exercise and your pain goes back to baseline relatively quickly, it is safe. It is safe to do that. If you tore your hamstring and you're back and you're trying to do a stiff-legged deadlift a week after your hamstring tear, and you go to do that, and after you finish that set, you went from a 2 to a 5, and it's because as you were trying to come up off the ground, you were shifting and you couldn't move the way that you want to, too much of a load. So you can't say a typical percentage, but it's as long as you can move the way that you want to, and that your pain at that particular injury site returns to baseline very quickly after you stop that movement, you're safe. If pain continues to creep up as you do more and more, you need to take a little bit off. But what is it going to require that you do if you're trying to put as much load on it as possible? Is you're probably going to have to reduce the amount of volume that you're doing. So instead of doing 3 sets of 5, doing something like 7 sets of 2, 6 sets of 3, keeping the sets shorter so that you don't have fatigue starting to impact the way that you want to move. But the main concern is that you move the way that you want to move. If you're compensating for it, it's too heavy. Move it down. But then you want to progress it as quickly as you can. All right, yes,
so
sir.
for the kinesiophobia, you were telling us that there are people who provide us the wrong information.
Yes.
Can you provide us with something that has a source of right information or correct information, besides Scott and John and Gretchen? They're good enough, by the way.
One particular person who is very, very influential in the sphere, and he is an interesting personality. He's an interesting personality, but probably the most visual or the most known individual at this point is a person named Adam Meekins. I think he goes by the name the sports physio. So everywhere else in the world, physical therapy is known as physiotherapy. But he is a British physical therapist or physiotherapist, and he has made it his life's ambition to combat kinesiophobia. He's an interesting personality. He is a far more colorful personality than me, and so his information is much easier to tolerate because it's not quite so, not like it's coming from an automaton, which I understand. That's my personality.
I was actually going to ask you about Adam Meekins because he's undergoing a trial right now for and for using foul language, apparently, is what they're
Yes.
after him about. But he seems to depart from the traditional physical therapy model, and I've seen him actually advocate for people to lift deadlifts with lumbar flexion,
Yep.
to just because the body moves in a number of different ways. And that was actually what I was going to ask you about is to what extent do you agree with that fully? I mean,
There is one particular subject, and I would have to like kind of scroll through some of his stuff. There was something that he posted not too long ago that I didn't quite agree with, but it was not necessarily semantics, but there was something minor that I really disagreed with him about. But all in all, the overwhelming majority, if not just, almost everything he puts out is very, very good quality information. And yes, his take on lifting with lumbar flexion, it's not dangerous. It's not dangerous at all. Is it optimal for what we're trying to do and develop strength? No, not at all. Not at all, because you obviously cannot lift with lumbar flexion as consistently or as much as you can the way that we teach it. All right. So our model is based off of efficiency to try to develop strength the best way possible. Now, if you wanted to add lumbar flexion or rounded back deadlifts or whatever into your program, how would you do that? You would start and you would kind of do essentially kind of like a novice linear progression. And so a novice linear progression or repeated exposure to increasing stress, exactly the same thing. All right. You're just increasing the exposure to stress over time. There is virtually no movement that is within reason that is inherently dangerous. Having your foot planted on the ground with extreme rotation about the knee and somebody hitting your knee on the outside,
right,
inherently dangerous because that's a great way to tear your ACL. But stuff that you do in the gym, most everything within reason is not inherently dangerous. What might be something that's inherently dangerous? Bench pressing without a structural safety. Bench pressing like in an open bench press with a thumbless grip, that is inherently dangerous. But does that mean that everybody who benches that way is going to have a bad outcome? No, but if something bad happens, it can be very bad, right? But is it the bench press or is it the lack of safety that makes that inherently dangerous? It's the lack of safety, right? So no, Adam Meekins is actually probably one of the best in the entire world at addressing kinesiophobia in a way that is more appealing to the Instagram consumer.
Yeah.
But his review of the literature is spot on. It's spot on almost every single time. the individuals that he has a big problem with, that he's very upfront with combating them, know that if he's actively combating them, they're some of the worst in this whole kinesiophobia sphere.
That's why I think he was being persecuted personally.
I think that in a particular setting that he practices in, he is more of a statistical outlier in the NHS system for physiotherapy than I am for the American physical therapy, because more physical therapists are starting to move towards what I'm doing. So I think that is probably more of a vocal outcry that he is actually impacting the business of other NHS providers, and it probably has more to do with that than it is. And the American Physical Therapy Association is actually, so the governing body for physical therapists in the United States is actually pretty open to different paradigms of treatment as long as it's justifiable. So we're just in a better system to where you can practice outside of traditional physical therapy, and it's for the most part it's taken very well. I know there's got to be other questions. Yes, sir.
If you come to the conclusion that you need to see somebody medically for like an injury, how do you make sure that you find somebody that's like good for you?
Probably your best bet is the community that you have right here. The community that you have right here. So there is going to be somebody who goes to a physician, a physical therapist for an absolutely necessary issue, and they're going to find somebody that, one, knows that you lift weights, is totally okay with it, is fully supports you doing it, and then that becomes the person who treats everybody here. All right. So ask around. Ask around. This becomes a little bit problematic whenever you work in an HMO system. Like, so you have network providers, and some of that is just trial and error. But there's also, you could see some of this sometimes if you know who you might want to go see. A lot of places, facilities will have biographies of their providers. Look for somebody that has an athletic background, somebody that competes in powerlifting, somebody that pursues athletic endeavors. They're likely to be much more responsive to you pursuing athletic endeavors than somebody that, and as much as I hate to say this, find somebody that looks like you. Find somebody that looks like they train. Because there's a lot to be said about book knowledge and real world knowledge of what it takes to train consistently, and I probably wouldn't put one over the other as far as effectiveness.